All right, welcome everybody. So today we're going to talk about neurocognitive disorders and delirium, and I'm going to make this very clinically. So you know how I've said to you every week just about there is no thing called mental illness, right? We can't see it on a scan. It doesn't come up in a blood test. We don't know what to do with it. It's all a diagnosis of exclusion. Well, good news, good news. There is a thing called neurocognitive disorders. This you can see on a scan. You can draw some CSF. There's a biomarker. There's genetic tests. This you can diagnose. Empirically diagnose. You can take a history, and we have something called dementia and different types of dementia. And the behavior pattern is very distinct, and the management is distinct. And this is something you can do something about. Some dementias are faster than others, and speed is very important when you're talking about dementia because that will help you formulate what am I really dealing with. The other thing, though, that you need to not mix up is delirium from dementia or dementia symptoms that happen with a primary mood disorder, because all of those can cause dementia-like symptoms as well. So what's going to be important for you to realize is how is dementia diagnosed and which ones are reversible, which ones are not dementia, they're all technically, except for the reversible ones, all dementias are essentially a terminal condition. That means you're going to die of it eventually. The question is how fast. So a lot of what you will do with neurocognitive deficits is manage the decline and provide a lot of anticipatory guidance. Now, some will decline much faster than others, and that's a huge problem because some will decline in a matter of hours to weeks and then dead. And we'll tell you which one that is. And then there are some that will take weeks, months, and years. And then you'll have to manage that a little bit differently because the needs of the patient will change. This is one of the ones that actually doesn't apply to children, does not apply to pregnant women. So in terms of across the lifespan, this is generally middle age to geriatrics. And middle age is obviously very young, but it can certainly start young. Very rare cases of like frontotemporal dementia in people in their late 30s, early 40s. Huntington's is one of the other ones we'll talk about. That's pretty horrible as well. So that's something to keep in mind. And this is going to be all about how you deliver the news. So this is one of the most difficult diagnoses to give, especially in the aware patient. There's a lot of health and wellness news around this. So there's a lot of cognitive enhancement, and the supplement market is alive and well. I'll just tell you right now, the only effective intervention we have to mitigate dementia and cognitive decline is weight-bearing exercise. That is it. Weightlifting. That's it. Because why? That encourages neuroplasticity. Your head, your brain, your breathing all has to work in concert. It also helps tone the autonomic nervous system, which also gets derailed. So if there's one exercise you want to do after the age of 40, it's resistance training. Don't waste your time with the cardio. A couple of minutes here and there is good to go. Resistance training, that'll get you through. It's all about your protein and your lean muscle mass. That's all we have. The rest, window dressing, symptom management, and the same thing will still apply. We need to go after the sleep factors. So let me walk you through what we're going to do here. So first, the most important thing that you need to figure out is how to distinguish delirium from dementia. And you can generally do that by history alone. You don't need an advanced diagnostic tool to figure that out. And what we want you to do is to practice tracing the onset and the fluctuation and to clearly identify what is the core deficit. The DSM is going to tell you what's the syndrome, and that's all good and well because it's checkbox psychiatry, but what you need to figure out, what you're going to treat, is really going to be based on those research domains criteria, meaning what circuit is involved. Are they too awake? Are they too asleep? Are they too irritable? Are they inattentive? Are they altering consciousness? And that's really where you're going to focus your efforts. Is there no interest in eating? Is there apathy? Is there withdrawal, social isolation? All of that is neurologically mediated, and that's where the medications, which is typically what they're calling the nurse practitioner for, to do. This is one of the things you have to get right. The reason you have to get this right is because a lot of people play in psychiatry. right? You've got mental health counselor, social worker, psychologist, licensed whatever kind of counselor, mental health coach, pastoral care, the rabbi, anyone's playing in the field of psychiatry. But this is the diagnosis that you need to get right, because this is the one that you need to clearly identify, track what's reversible. Because if you have delirium and you show up in the social worker office and it's missed, you can talk about your feelings all day long and try to modify behaviors, but that level of consciousness is not tracking, that inattention is not working, the dementia is expected to decline. You really can't do a lot with that. So that's why this you have to get right. You guys and the psychiatrists are primarily going to be the ones managing this. Neurology also plays in this field, but much of neurology is diagnose and adios. This is your problem. Do you want Aricept and Namenda? That's my one-trick pony. That's all I got. Now, you've got 15 minutes because medicine is let's go. It's a volume operation, especially if you're billing insurance. It's a high volume operation. So psychiatry typically gets this because you have to do a lot of anticipatory guidance. You will work with the family, the caregiver, the responsible party. You are also the one that may get called by the court. So we're going to talk about capacity evaluations. One of the more common reasons psych gets consulted in acute care settings is, does this person have capacity to make this decision? So we'll talk about what are the elements of a capacity evaluation. Another thing is one of the major problems, one of the things that can cause dementia also is Parkinson's disease. That's a neurological disorder. You can diagnose Parkinson's. We'll talk a little bit about that. And we'll also talk about the dementia that follows it. Most of Parkinson's is obviously done in neurology, but most of psychiatry is practiced in primary care. So that's why you have something to bring to the table here. Other things we're going to differentiate. You need to be able to differentiate Alzheimer's from vascular, from Lewy bodies, from frontotemporal, from Parkinson's, from normal pressure hydrocephalus. Each of those has a signature that you're going to learn to figure out. And then we'll talk about decisional capacity, the difference between competence and capacity. Those are two different things, but the short and the long of it is competence is a legal designation. Capacity is a clinical designation. And capacity depends on what is going on at the moment, what you're expected to decide, and it changes moment to moment. Does this person have capacity to receive care? Does this person have capacity to refuse care? Can they stop dialysis? Do they have capacity to manage their finances? Do they have capacity to, and then that's the question you're having to contend. And that changes because they may not have capacity because they're intubated and sedated. They might not have capacity because they're temporarily delirious. But when that resolves, you reevaluate the capacity, it can be restored, depending on what's the reason for the incapacity. And then finally, we're going to show you how to do a little bit of a care plan and some family coaching strategies, and we'll do some case studies at the end. So that's what we're going to work on here. So before you diagnose a disorder of cognition, you need to define what is cognition. What do you mean by cognition? And really what we're talking about is attention, memory, and executive functioning. Those are the three elements of cognition: attention, memory, and executive function. So let's talk this through. So when a patient is forgetful, this is like an orchestra playing off tune. So when they're forgetful, they could be forgetful due to inattention, meaning the message never was received. Memory, they can't hold on to the short-term or long-term information to give you what you're looking for. They can't encode and retrieve. And then there's executive function. Can they plan something, reason through it, and execute the whatever it is they're thinking about? So that's the executive function. They can't do any one of those three, cognition is said to be impaired. So that's what we need to talk about. So there are multiple tests that you can do, and each test is going to check a specific domain. So for example, you may ask for a digit span test. So I'm going to give you a number, 2709. And they're going to repeat back, 2709. Start with 2, add a third, go to the fourth. And then you ask them, give it to me backwards. 9072. They should be able to take that number in, hold on to it, and process and give it back to you in a logical sequence. And they may not be able to do that because, wait, what did you say? Inattentive. I can't remember. And they're really searching because you know they got it because they repeated 2709 to you, but the memory piece is gone and they can't give you back 9072. See, that's the problem there. So you're listening carefully to what it is they can and cannot do. And it's also not binary. Cognition's on a spectrum. So you may have normal aging where the thought process is normally slowed, but it doesn't interfere majorly with the functional domains of life. So mild cognitive impairment will give you measurable deficits, but general function is going to be preserved. When you get to something like a major neurocognitive disorder, you are formally meeting that DSM criteria, and it has to impair function. What does this not allow you to do? What were you doing that you're not doing now? And that's what makes it rise to the level of a disorder. So your first question is never, what's the label? Your question is, where along the cognitive continuum is this person today, and what mechanisms got them there? How long? Where are we now? What is it you cannot do? That's what you're listening for. So that's where your questions have to focus around. Now, take a look here. This is the RDoC framework. And the reason I do this is because medications only work on biological processes. So I need you to have a biological theory as to why they're not doing what it is they're supposed to be doing, or why they're doing, say, too much or different than what they normally used to do. And I need you to have a biological theory, not just that they met a checklist in the DSM. So the DSM will tell you what a disorder looks like. The RDoC is supposed to help you understand why this is happening. So when you see a patient with, say, fluctuating attention, or apathy. The question isn't just which diagnosis fits, but which circuit is misfiring. And that's what you need to listen for. Which neurotransmitter system is dysregulated? Because think about the drugs you are prescribing them, right? That's what we're working with. So you'll have cognitive, positive valence, negative valence, arousal problems, sensory motor problems. That's the blueprint. So what you need to figure out now is which one is firing properly or not. So for example, if you were to see a flat affect, is it a negative valence issue or an arousal regulation problem, right? If they're just flat, are they flat because they're sleepy, or are they flat because they're depressed and withdrawn? That's what you're trying to figure out. So you can live between these DSM boxes, and people with vascular dementia and depression are going to share some disruptions, right? Because if that circuit is not being perfused due to vascular reasons, that's obviously not going to give you proper functioning in that circuit. Well, likewise, if the person is flattened, not due to vascular issues, but because they have, say, major depression, that also is not going to fire, but the approach is different. So what we're going to do is target these different domains of what it is you physiologically want the person to do. I want you more awake. I want you more attentive. I want you thinking clearly. I want to increase your motivation. That's what we're working on when it comes to pharmacology. And this is not psychopharm, but let's be real. Most of what psychiatry is pharmacology. So that's why we need to really be clear as to what we're doing. Okay. All right, so let's unpack this with the cognitive system. So this is attention. This is the gatekeeper. This is the thing that decides which stimuli make it into your consciousness, and when it fails, everything downstream, including memory, language, and reason, fail with it. So executive attention is the bouncer at the club, say. It filters noise so the brain can focus. This is the thing that gives us a declarative memory. It's your archive. This is the thing that encodes facts, experiences, and then retrieves them when needed. If encoding fails, you never recall it later, meaning it never made it into the process. So Alzheimer's begins here. Okay, it's an encoding problem in the hippocampus long before the language falters. Language is the next circuit. That's the most human circuitry there. Okay, for our intent and purposes, we're the only ones with advanced language. And if you think about what advanced language allows us to do, you can see how devastating this can be to daily function if that starts to fail. It's not just speech. It's comprehension, it's tone, it's nuance, it's reading the room, all of that. That's what we mean when we say language. When this network degrades, like say in something like frontotemporal dementia, this results isn't word finding difficulty, it's the collapse of shared meaning. So cognitive control is like the brain CEO. That's when they say top down approach, right? Rather than bottom up. Top down approach means I'm going to think about it and then do it. Bottom up approach, my body's just doing it, and then the cognition and the stuff will follow later. So think of this when you see a patient who perseverates, right? Meaning they're stuck in a loop through the same question. And then finally, there's this concept of working memory and flexibility. That's the mental workspace. Without cognitive flexibility, the person can't hold multiple ideas in their head or adapt to the environmental changes. That's the person that you say, maybe they're delirious. Okay. This is the person that's going to fail doing a test like serial sevens. Now, I'm going to fail serial sevens because I've never been great at math. And I just have to do that. And I've always done this. So you kind of need to know what the baseline is. The other thing is you have to remember cultural context. So the younger generation has likely never seen an analog clock. A what? An analog clock, the one with the circle and the arms and the numbers all around. Well, that's going to be a problem. We're going to have to come up with a new test because if your whole life has been digital and I tell you, draw me a round face clock, put all the numbers on it and make the time 10 minutes past 11, it was never in there to begin with. So I can't say you're demented for not being able to do it. You see the problem? So we need to kind of adapt in doing that sort of thing. Okay. So let's take a look here at the different types of dementia. So how do these constructs play out? So for example, in Alzheimer's disease, declarative memory is the first to fall. This is due to, well, this is the theory. This is the neurobiological theory behind it. And you can map this on a brain scan when you image them and you see. But the hippocampal circuits are losing their efficiency and the episodic recall is fading here. So patients can remember the 1950s, but they can't remember what they got for breakfast. In vascular dementia, this is not a memory, it's a processing speed and executive control problem. And so the fronto-subcortical circuits are suffering from these little microinfarcts. So when you do a brain scan, it'll say like microinfarcts, white matter changes, right? Chronic vascular ischemia. Those are the sorts of things. So each one is small, but collectively you have a lot of these little infarcts over time. You can see how parts of the brain are going to fail. Processing speed will go down. Do you know the leading problem, the leading driver of vascular dementia? Uncontrolled hypertension. So that's a big, important thing to remember. You're not going to be able to contend with the vascular dementia until that blood pressure is well controlled. And in the elderly, you have to be careful. Well controlled. They've gotten used to these high 180 pressures. So well controlled has to be gradually done. The other problem, of course, is we're talking damage over time. This was not a one and done event, wear and tear. By the time they come to you, we're really working at the margins at that point. We're trying to keep it from getting worse. We want to keep you from having further strokes, worse strokes, more microvascular changes, God forbid, a brain bleed. That's really what we're working with there. So you're not going to control vascular dementia's decline until you learn to control the blood pressure. So that's very important to keep in mind. So you'll have a good relationship with primary care cardiology or renal and say, hey, can we work on this blood pressure a little more? And further, you're not going to make it worse with, say, SNRIs. Because SNRIs can raise the blood pressure. But SNRIs are one of our first go-to drugs when we want to enhance cognition and attentiveness. You see the problem? So you need to make sure that blood pressure is well controlled before you put on an SNRI. And when you do start it, you better follow up that blood pressure, whether it's home monitoring or in the office or a nurse visit or however you decide to, but you want to make sure you're not making it worse just because you think you're making it better. The other one we need to look at here is Lewy body dementia. This centers on perception and visuospatial attention. These people are misinterpreting patterns. They're seeing people in shadows or animals on the floor, or I see little dwarfs, or I see small animals or small children. The cognition here is fluctuating because their arousal regulatory network is what's misfiring in this condition. Another thing with frontotemporal dementia is this disinhibition that they develop. The patient who once knew boundaries now starts to tell off-color jokes. They may suddenly become disinhibited and suddenly racist. They may make sexual innuendos. They may start to shamelessly flirt with people. They may expose themselves, start grabbing people inappropriately because the part of the brain that's regulating is broken. Now, you need to know that and not take these things personally. I can't tell you how many nurses and nurse practitioners and physicians, even and healthcare workers, take it personally that he said, what about my what? right? This is the person, they'll just come, you've gained 20 pounds today, haven't you? You don't look like you've missed a meal in weeks. They'll just say whatever comes to mind. There's no filter. And you kind of have to let it go in stride. You can correct and remediate as much as you want, but you may as well talk to the wall because there's nothing being held. So you just need to do anticipatory guidance, teach the healthcare team, this is part of the disease. It's not that he never loved you. They will say things like, I never loved your sister. You were my favorite one. And then 2 minutes later, that horrible person, get her out of here. But that's not, it's not willful. And they'll say, oh, and people will project. So your knowledge of defense mechanisms will come, I knew he always felt that about me. Oh, I see. Okay, I see we're having some projection going on here. But this one's the patient, not you. If you want to deal with your projection issues, here's my card, make an appointment. But for now, we're working on you here. So just keep that in mind too. So this person will have disinhibition, apathy. They will lose empathy for others. And this all stems from a degeneration of the orbitofrontal cortex. Orbitofrontal cortex and the anterior cingulate. They also will lose their moral compass. They have no problem shamelessly lying, but they don't know they're doing it. It just feels right and they just go with it. So it's not to be taken personal. The other condition you need to note here is delirium. This is the ultimate arousal and attention disruption. This is due to the reticular activating system faltering. Remember, that's the same thing that also controls sleep. Keep that in mind because one of the most important things you need to do for dementia and delirium is regulate the sleep cycle. Right? That's why we say open the shades, window by the bed, get them moving. We're trying to manually fix through habituation the sleep-wake cycle that has become disrupted. Delirium is not simply confusion. Okay? Delirium is a failure of awareness to stay lit. So there's a pattern for each of these, and each pattern you will become more familiar with. So like anything else, you always have to go through this systematic approach because it turns out substances can cause this, yes? Yeah. So it turns out substances can also, no, there we go. Sorry about that. Substances can also cause these alterations in sensorium. So you need to make sure that you're not missing something reversible. So before you call anything dementia and delirium, you first need to rule out factitious and malingering. Okay. And you also have to look at who's bothered by the problem because the factitious and malingering can occur in the support person. They may be presenting their loved one for care, reporting a host of symptoms. And then when the person denies it, you'll say, oh, they can't remember. But you need multiple sources of corroboration. Okay. Not just the daughter says they're forgetting. That may be true, but I need to know if that's real or she's overreading it. Right? I don't know. I don't know if you're just looking for a reason to put them in a home. I don't know, but I need to verify. Okay. Now, I'm not saying people have malicious, nefarious intent, but some people have malicious, nefarious intent. So you need to be careful with that. You know, they may want them to execute a new will. Now, I've had this problem pop up where I see a patient, he's obviously demented. He's got a wife and a girlfriend, and they know about each other. And the will is made out for the wife and the children. And the girlfriend decides, I want to be the star player in this sort of thing. And so they take this person off to another venue because he likes to vacation, say, in the South somewhere. And they get someone to put a new pen in his hand and execute a new will. And then after he dies, no one finds out and the will is contested. Oh my God, did that man have capacity to even execute the new will, or was he too demented when you saw him that that's not possible? This is why your documentation around this matters so much. I've been involved in cases like this so much. The more money that's at stake, the more your notes are going to be contested. So just be careful. Document clearly. Document clearly. What do you have? How long have you had it? How did you verify it? That's what you need to figure out. Now, if a patient's presentation fluctuates perfectly with observation, you need to think about secondary gain. Is there a gain for disability, housing, attention? Are they trying to mimic pathology for some reason? Because you just need to rule that out. And then substance-induced conditions. That's kind of a big deal. And how might that be a factor? Well, There are a lot of people on long-acting benzodiazepines that have been for years, and benzodiazepines can alter cognition. Marijuana is becoming ubiquitous. They might be high on marijuana, or they've been on it for a long time, and cognition's impaired that way. Alcoholism, a little goes a long way, especially when you're elderly, and so you might miss that. Could they be hungover? Are they in a withdrawal state because they used to drink and they're not drinking now? All of those need to be considered. Then, of course, this is your main bread and butter here. It's these underlying medical conditions. And the underlying medical conditions is what's going to help you realize that this is not some long-standing untreated hypothyroidism. This is not a hypertensive encephalopathy. This is not a urinary tract infection. They're not dehydrated. They're not having a pneumonia. This is what the underlying medical conditions are that you need to rule out. They're not going in and out of AFib. Those are the underlying medical conditions that you're trying to figure out. And of course, the adjustment to, are they devastated by some news that they're in denial and they seem detached from reality and they're dissociating? See, that's the distinction there. Because old people can dissociate also. Old people can be traumatized as well. So you have to say, when did this start? And what was going on at that time when this started? Well, her husband died and she's never been the same since. Oh, interesting. So now you have a very narrow context. So then you want to figure out, is this prolonged grief? Is it truly dementia? Was he the glue holding them together and covering for the shortcomings? You don't know until you ask. So that's what I mean. You just need to be very systematic about the approach. And you'll do that 4P formulation. What's the presenting problem? Why are you here? In this case, it's usually memory's gone, or I feel my memory's lacking. Oh, here's the other thing that happens. They can be aware that the memory is failing, and they're very anxious about it because in their mind, it means they're becoming more and more debilitated and they're losing independence. So now I don't know if the anxiety is exacerbating the cognitive dysfunction. Did it cause a secondary depression, which causes dementia-like symptoms? So that's the tricky part right there. They may freak out because they too much Instagram or TV and they can't find their car keys and they think, oh my God, it's the beginning of dementia. And then they panic and they get stuck in this loop of panic and despair. I can't hear, I don't know what I'm doing, et cetera, right? The other thing is you need to make sure that they don't have a true sensory deficit, cataract, right? Hard of hearing. Things that are affecting the visual inputs need to be remediated. If you don't deal with the hard of hearing, that can accelerate dementia. If you don't deal with the blunted sensory inputs, that too can do it. Now, why do you think that's the case? Well, if you don't use it, you lose it. So if you're not stimulating that part of the brain that processes those auditory signals because you can't hear them, you're going to lose that part of the brain. And people will mistake hard of hearing for dementia. They're repeating and talking louder because there's a sensory deficit, not because they're demented, but in the wrong hands, that could be misperceived. So that's another thing to keep in mind. And then, of course, when you look at the precipitating factor, that's often the tell as to what brought them in today, especially if it's an underlying medical condition. Oh, that's why you're here. Let's rule this out, see what's reversible, and send you on your way. The perpetuating factor, this is the thing that you can work on. You can only work on perpetuating factors like I need you to sleep, I need you to eat, I need you to get physical exercise, I need you to socialize. Those are the things I can work on. Can't really do much about what has happened before now. So your efforts are always aimed at perpetuating factors. The protective factors are the things that make you say you don't need to be in a home, you don't need 24/7 home health aid, you can still live alone, maybe you do take the car keys or not. I mean, these are the decisions that they're going to bring to you and you're going to have to help them make. Okay, so delirium is one of the few psychiatric syndromes that can kill you if you miss it. So the history and physical, if you only had 5 minutes, what would you check? You only have 5 minutes, review the medications, especially looking for anticholinergics, look for benzos, opioids, and tramadol, however you're classifying that these days, okay? Because tramadol is serotonergic and it can make you more irritable. It could also constipate you, which can trigger a delirium. And if you don't take it and you've been on it for long enough, you can have a withdrawal state. So look at the medications if you only have 5 minutes. Then you want to ask, when did this start? Does it fluctuate? And does it worsen at night? Even small environmental shifts in pain, sleep loss, restraints, all of these things can trigger a collapse in an already vulnerable brain. And so you start broad. How do you work this up? CBC, basic metabolic, liver function, TSH, UA, oxygen saturation, vital signs. That's not unreasonable, right? Cover your bases. Maybe you expand to a B12 folic acid toxicology screen and ammonia level if they act the part. But really, you need to make sure you're not missing something reversible. Delirium is a metabolic condition until proven otherwise. The other thing you may think about, if it's acute, head imaging has a role here. CT or MRI if you suspect a stroke, a trauma, or if there's no metabolic explanation because maybe they fell and no one was there to see it. So that's why head imaging is indicated in neurocognitive deficits. And never forget a subdural hematoma can masquerade as psychiatric confusion and symptoms. So look for that. Other workups that you might have to do here are things like an EEG. You can order an EEG as an outpatient routine. Typically, if you order it, you're going to also be making a neurology referral. But also keep in mind, EEG will be affected if they're on any, say, neuroleptics, like, say, anything that works on the seizure threshold. So valproic acid, lamotrigine, benzodiazepines, lithium, all those things affect what you're seeing on an EEG. Now, you're not going to read the EEG. You're going to get a report, but you want to know what to do with that report. That's why I put it here for you at your disposal. An EEG may be the only thing standing between confusion and coma. Maybe they could be having silent seizures. So you want to, it's cheap enough, it's easy enough, it's non-invasive enough. Don't forget an EEG if indicated, okay? Even in the most resource-limited settings, you can always do a CBC, BMP, chest X-ray, oxygen saturation. So that's something to pay attention to. The chest X-ray may be negative for pneumonia if they're dehydrated because you need fluid to fill the space. So if they're dehydrated with the pneumonia, you could miss it. And keep in mind, it could have happened over time, so they've had time to acclimate. So they may not be sick enough to be in the hospital, but they may be sick enough to where they're acting delirious, and here they are in your office. Or if you do consultation liaison psychiatry, then they are in the hospital, and you want to make sure that those things have been ruled out. Don't assume they have been. When you read that chart, go with a fine-tooth comb and look for what they did, but also what they did not do. Okay, so here's the question. Is it delirium or dementia? Well, delirium hits like lightning, hours to days. That's one way to tell. The onset. Dementia creeps up months to years. So if the family says they were fine last week, that's delirium until proven otherwise. Delirium is a failure of attention and awareness. They can't sustain focus, follow a conversation. Dementia is a failure of memory and integration. They can attend to you, but they forget what it was said and they just kind of, don't seem bothered by it. In delirium, it's often reversible when you treat the underlying cause. Dementia, by definition, progresses and is expected to decline. And the major decline is that erosion of independence. Things they once could do, now they can't do. With respect to hallucinations, delirium hallucinations are chaotic and threatening. For example, think delirium tremens withdrawal. That's delirium. They may see spiders, intruders, creepy crawly things, hallucinations and stuff. In dementia, hallucinations are rare, except maybe in Lewy bodies or toward the end. The other thing to keep in mind is in delirium, they see things that aren't real, but in dementia, they believe what they're seeing. That's a big tell there. Do you see things? Yeah, I see things. Do you believe them? No, but I see them. Okay, that's delirium. Other people that will do that, like the Charles Bonnet visual hallucinations, people with cataract can have a visual hallucination as well. I see it, but I know it's not real. I see it right there. That's the distinction. If they believe it, that's dementia. Okay. So the other thing is with respect to consciousness, delirium will cloud it, dementia preserves consciousness. So that's a major tell as well also. These are not, so in delirium, its definition is a waxy, waney level of consciousness. They're attentive, they're inattentive, they're hypoactive, they're hyperactive. It fluctuates by definition. Dementia is persistent. It's a persistent decline gradually over time. Delirium, I'm on 1 minute, gone the next. And that's another way to tell the difference. Don't miss it. Okay. So one of the hardest skills to pick out here is what is normal aging from pathological decline? So what changes with age and what doesn't? Well, normal aging will bring mild forgetfulness. Where did I leave my keys? But preserve function. They forget where they put the keys, not what the keys are for. There's also progressive decline, so there's no interference with independence. That's not dementia. That's biology doing its job. Okay, that's normal aging. Mild cognitive impairment is in the middle of normal aging and dementia. This is the in-between one. This sits in the middle zone. One or more cognitive domain is slipping, often memory first, but daily life is basically intact. They may use lists, routines, reminders, compensatory scaffolding in their life so that they can kind of retain the independence and keep going. This is the window. 10 to 15%, by the way, of people with mild cognitive impairment each year will progress to major neurocognitive disorder, dementia. So that's important to keep in mind. It is progressive. Only about 10 to 15%. Not everybody with mild cognitive impairment is going to progress, but there will be some that do. Now, so the deficit for neurocognitive disorders, major neurocognitive disorders, have to span functional thresholds. So, for example, losing bills, kitchen hazards, leaving the gas on, disoriented, getting lost, wandering, common things they could commonly do, not just memory. You're looking for signs that demonstrate to you there's a collapse in their autonomy. They've become a danger to self. Could be through neglect, benign neglect. Forgot to eat, food is going bad in the fridge, stuff like that. Did I take my pills? So I took them again. Now you have an underlying medical condition. I didn't take my pills. Yes? Absolutely, you can. In fact, that patient with dementia is more likely to develop delirium. It's a vulnerable brain. So you can have delirium de novo. You and I could be delirious. And then if you have dementia, you're more likely to have delirium. So this is why we want to be really careful with the elderly, especially if there's dementia, with new medications. Staying on top of hydration and elimination, huge. Be careful with relocation because relocation can trigger a delirium. There's a concept called relocation delirium. What you do in that instance is you have broken the, my battery's running low. Why? Oh, shoot. Yeah. The plug. So what's happening is with relocation, they're losing the normal rhythm of life that tells them what to do and when to do it, right? So if you mess that up, that's a problem. There's a thing I saw, and I thought this is the most horrible thing ever, but they think it's a great thing because they're not selling to the patient, they're selling to the family members. A dementia cruise. Oh my God. When I saw this thing, I'm like, is this to accelerate decline? You are going to take a person with dementia who's vulnerable, put them on a ship where the ground is rocking, put them at sea, change the sleep-wake cycle, change the environment, and overstimulate them with crowds and a buffet where they have to make 100 decisions. This was a great idea. Bring your loved one. We're ready to handle them. Oh, you have no idea. I'm curious to know how many people wind up in restraints and on Haldol by the end of the ship, because at the end of the day, those family members are not going to hold it together. So I don't think that the dementia cruise is a great idea. You will get asked this a lot, by the way, if you work with the geriatric population. We like to go to Florida for the summer. Can we go? You can, but I would say don't come back next summer or next winter for, New York because you keep relocating them and they keep setting the stage for delirium, and the delirium sets them back and could cause a precipitous decline in their overall function. What you want is routine, predictable day-to-day with someone with dementia and delirium. That's what you're looking for. Anticipate their needs, and even to the point where it's meatloaf on Mondays, lasagna on Tuesday, Wednesday is chicken, and Thursday is pork chops, and Friday is fish, and Saturday is I don't know what. Right? But you want that. You want as many environmental cue markers as possible. When you go to long-term care settings, you may notice that they have things like what's going on the calendar wall there. Today is Saturday, whatever, right? Today is October 29th. It's Wednesday. It's evening, and the thing changes like that. You want as many ways for them to read the room as possible because that's reorienting. Because the last thing you want them to do is panic, get anxious, and then really decline precipitously. Where am I? Who am I? Who are you? That kind of thing. So that's why it's important to maintain routine and predictability. All right, let's talk about the most common dementia. Alzheimer's dementia is the most common. This is a slow burn of cognition. This is insidious onset and gradual worsening. Think of vascular dementia like a staircase. Alzheimer's is a ramp. This is a slow ramp. This is the first domain to fall. You'll find declines in things like episodic memory. The brain's archivist, the hippocampus, is failing. It's not binding to new experiences. You can test it in 5 minutes, give 3 words, distract them, and ask to repeat those 3 words again. That's a good tell. If they can't encode, they can't retrieve. And what you'll see on imaging here is hippocampal and medial temporal atrophy. You can see that. You can also do a PET scan for this dementia and the temporoparietal areas. You'll see things like hypometabolism. So in cancer, you do a PET scan and you're looking for areas of hypermetabolic activity. That means that the cells are rapidly dividing and consuming glucose. In dementia, it's the exact opposite. The cells aren't rapidly doing anything. They might be on a fast or not eating at all. And that's what they call a hypometabolism. The glucose is not being taken up in those cells that should be active. The brain's a big consumer of glucose. So if it's not being taken up, it's not working. So that's something you will see on there. You can also do a CSF, and you're looking for low amyloid, beta 42, and high tau. Those are the proteins in the CSF you can do. It's not essential to do it. And just because you have them, it doesn't necessarily correlate with severity of disease. Also, it's a lumbar puncture, so you have to deal with the headache and the recovery period and that sort of thing. So just keep that in mind. There's also a blood test you can do. It's called a p-tau 217. Yeah, you don't have to. Just know it's out there. If you go into the dementia world, this will be your bread and butter and you'll do them and that sort of thing. But you can diagnose Alzheimer's without this based on pattern and pattern recognition. So what we're looking at here in Alzheimer's, the problem is the disordered or disrupted memory circuit and processing. So that shift from symptom to system should transform how you think about this. So the brain cannot store new experiences. Got it? That is Alzheimer's. The brain can't store new experience. So of course, can you do CBT effectively with somebody with Alzheimer's? I mean, that requires a high degree of storing, retrieving, and acting. Vascular dementia, this is entirely different. Now, Alzheimer's is a gradual downhill. Vascular is a stepwise decline. So you'll have plateau and then precipitous drop and then plateau and precipitous drop. And the million-dollar question they will ask you every time, how long does it take? I can't tell you. It's different for everybody. You may be on this plateau for a long time and then have a precipitous drop. I can't tell you how long it's going to take. And that's the most frustrating. I mean, I have many adult children. How long could this possibly go on? I don't know if the funds are going to make it. I've already got her in assisted living. We're going to move her to memory care. Now she has 24/7 home health aid in the assisted living, and we are hemorrhaging. How much are you hemorrhaging? 20 grand a month, 30 grand a month, easily. If you want 24/7 care with a personalized aid, that's the numbers you're talking about. Not to mention the 15,000 baseline for an assisted living studio in Manhattan, if that's where you're going to do this. Price drops precipitously if you leave the New York City area, and none of that is covered by insurance. Say again?
15,000 a day.
15,000 a month. A month, 15,000 a month for rent in an assisted living, not memory care. Not memory care. Memory care probably goes to 20 for a studio and not a personal aid. So it's high. It's high. So this is where long-term care planning comes into effect as well. So life insurance policies, long-term care insurance policies. This is where you will work with wealth managers and elder care attorneys. You're all hearing this. When you turn 50, 55, or 60, speak to your estate planner, figure out when the best time is to buy long-term care insurance, because that's a major factor. So life insurance cares how soon will you die will pay the policy. So life insurance will kind of boot you out or raise your premium if your mortality rate is high. Long-term care insurance is interested in your morbidity. How many ADLs are you going to lose, which means we're going to have to start paying for some sort of assisted living, skilled nursing home. So that's what they're looking for. So in general, you don't want to be within 6 to 9 months of any sort of physical therapy or rehab at all before you purchase the long-term care insurance. Because if you are, it's a good indication they may not insure you. And then that's a problem. And you might reapply later, but keep in mind you're older, and so that too will affect your premium. But so what's the take-home message at your age now and forevermore and for all your patients? Weightlifting. Weightlifting and Pilates. Strength, balance, flexibility. That's what you need to age well. Strength, balance, and flexibility. All that other stuff you're wasting your time with, we don't care about that. Strength, balance, and flexibility. Yes?
Hasn't diabetes also been tied to a lot of these neurodegenerative disorders?
Yeah, so insulin resistance is a major culprit here, right? So that's why having lean muscle is really important. Some people have speculated to call Alzheimer's type 3 diabetes, insulin resistance in the brain. Great, good to know. I don't have a way to fix it other than to make sure you have a lot of lean muscle mass. That's all I got. Yes?
Nicotine.
So there's the problem. I love nicotine for this population. The problem is I can't really say or do that in practice because it's got such a bum rap. Here's why. So nicotine has been in cigarettes, and cigarettes are the spawn of the devil and cause cancer, and that's been the mantra ever since. As a result, I don't think we can do research with nicotine in good faith because you're going to spend forever trying to convince people this won't give them cancer. Nicotine doesn't actually cause cancer. It's the crap in the cigarette that you burn. That's the cancer part right there. The tar, the additives, the burning part is bad. That's the carcinogen. So you can have an informed conversation with the patient and say, do you want to try a nicotine patch? Now, keep in mind, you're putting an elderly person, likely with some sort of cardiovascular disease and hypertension, on a stimulant, right? So therein lies the problem. Are you raising the blood pressure and raising the heart rate? That's a problem because they're dehydrated. Their heart rate will go up and they're more likely to, kaput that way too. So it's a tightrope. I would say I don't do it. Theoretically, I understand why it works because nicotine is indeed cognitively enhancing, but it's a high-risk vulnerable population, and the benefit really needs to outweigh the risk, especially if you're going to go off-label. So I think it's a good area for research, and I would love to see research done on it so that I could one day say, yes, here's a nicotine patch. It's probably safer than, say, I don't know, SNRI, Ritalin, et cetera, but I can't say that just yet. But yeah, it is known to be cognitively enhancing. Some of the younger college kids will actually try to enhance their cognitive performance by vaping higher doses of nicotine or putting on a patch. Think of it like steroids for weightlifting. They're doing nicotine for academic performance enhancement. Live with your own souls. But it's going on. I don't recommend it. It comes with a host of issues. It is addictive, by the way. That's why it's in the cigarettes. So you don't want to trade one problem for another. Okay, Lewy body dementia here. So this is manifested by fluctuating cognitions and fluctuations in attention. These are the ones that have visual hallucinations that are well-formed and detailed. This is the signature of Lewy body dementia. So one day the patient tracks perfectly, and then the next one they're staring through you. This is the waxing and waning bit of attention and alertness, but it's not mood-based. And the visual hallucinations are well-formed and odd and specific. Usually they're seeing things like animals, small children, things like that. There is a prodrome here. So the prodrome here is they will have physical symptoms like rigidity, bradykinesia, and some cognitive changes. So when I tell you rigidity, bradykinesia, what am I kind of describing to you? Early Parkinson's, right? So a lot of times you'll have Parkinson's 10, 15 years before you have this. And sometimes you have Parkinson's and then a year later you get another kind of dementia, but this all tends to look the same. So that's what this Lewy bodies is here. You don't want to give this patient Haldol because what will happen is you can precipitate the rigidity because of the neuromuscular interplay there. So you have to be careful with them. The dopamine system in these people is quite fragile. So if you have to use an antipsychotic in this population, it's quetiapine or clozapine. Now, clozapine comes with 1,000 problems in blood monitoring and et cetera, et cetera. So the antipsychotic of choice, even with the black box warning, and we want to avoid it at all costs, but if you have to keep them safe, it's Seroquel, and start as low as you possibly can, 6.25, 12.5, that low, and see what happens with it. But you want to avoid it at all cost because there is this black box warning of increased risk of cardiovascular death with antipsychotics in people with dementia. But sometimes I need to keep you out of the emergency room. I need to keep you from eloping. I need to get you to sleep at night. So sometimes you have no choice but to do it. But I recommend all the environmental things first before you go into an antipsychotic. Let's talk about frontotemporal dementia. So frontotemporal dementia, this corrupts your character. There's a behavioral variant of this, and it starts subtly. Poor judgment, apathy, and compulsive routines. Okay. Respected pastor starts swearing in public. Start thinking of something like that. A meticulous accountant may start to shoplift, randomly. You don't know, where did this come from? Why are you stealing things all of a sudden? The memory, it's still sharp though. The problem is there's this unrecognizable personality change. It's where the personality resides, in the frontotemporal lobe. So that's the clue, by the way, acute onset personality change with preserved recall. So that's why it can be missed as a dementia. The memory part is working, but the behavior has gone sideways. The other thing is there's a language variant here. They call that primary progressive aphasia. That's a language variant of frontotemporal dementia. So in the non-fluent type, you may have grammar collapses or speech becomes labored. They may have some semantic problems where grammar survives, but the meaning erodes. So they think they know what they said, but that's not what they really said. It sounds right. Grammatically, it's correct, but the meaning is completely gone. So they'll call a zebra a striped horse, something like that. That's where the grammar's right. Striped horse is not grammatically wrong, but that's not a striped horse. It's a zebra. That's the way you can notice that. And this is due obviously to fronto and anterior temporal atrophy. It's in the name, frontotemporal dementia. Inhibition also is gone usually. The frontal lobe normally is what governs your moral fabric, and that goes offline, and now you've become immoral. I had one patient that somehow convinced the home health aide she was going to become the girlfriend. She went along with it. She then saw herself as the girlfriend and stopped caring for him, and they would eventually engage in sex. And then the problem is that's a vulnerable person. Does this, and this is a big thing that comes up, does a demented person have capacity to consent to sex? Okay, and then let me just further complicate it. A married couple and one of them is demented. Does the demented person consent to sex with their spouse or not? Who's to decide? Right? That's a major question to think about. People will put this in their advanced directives. Honey, if I become demented, you can still have sex with me. It's fine. Okay. Right? So that's something to think about, but something you may not be aware of. And you'll be asked, you'll see this in nursing homes. So nursing homes, the elderly are hooking up like bunnies, apparently. STDs are kind of rampant in nursing homes, and they're not using protection because they're not worried about getting pregnant. But the question is, does the person have capacity to consent? And who said? This is Harry. He's my new boyfriend. This is Gladys. She's my new girlfriend. What was her name again? The girl over there in the wheelchair. That's my new girlfriend. Okay. So those are some things to keep in mind. I'm not going to tell you how to navigate that because every situation is different, but suffice it to say, you can see where the problem of capacity and consent gets convoluted. So a person with frontotemporal dementia can remember their demographics. The problem with this condition, unfortunately, can start as young as 40. And it can start to decline off in that. There's usually a genetic variant. So if you see early disinhibition, aphasia in a middle-aged adult, early disinhibition and aphasia in a middle-aged adult, don't quickly label them bipolar, which I have seen, and then we'll tell you why this is a problem, excuse me. But bipolar doesn't just randomly come out of nowhere at the age of 40. So age of onset of symptoms is very telling, okay? People don't just get psychotic at 50 and 60 years old. It's not when schizophrenia hits. We'll tell you when that hits later on, but that should immediately cue you in. This is an atypical presentation. You need to think about atypical problems. So you have to consider when you have these symptoms, could this be a degenerative condition? All right, so there are two biological siblings here, both alpha. Okay, let's see here. The timing is what separates these two problems here. You have Parkinson's disease dementia and dementia of Lewy bodies. And so there's a 1-year rule here. So Parkinson's preceded dementia by more than a year. We call it Parkinson's. If dementia appeared before or within 1 year of symptoms, then we call it dementia with Lewy bodies. It's just a distinction class. Treatment-wise, will be comparable. In Parkinson's dementia, you'll see hallucinations emerge later. They're often benign, and the person will know that they're unreal. In dementia with Lewy bodies, they come out early, they're elaborate, and they're central to the diagnosis. So it's a timing factor here. Both of these people are going to be sensitive to antipsychotic medication. One dose of a typical antipsychotic can suddenly trigger the rigidity, the confusion, and the neuroleptic malignant syndrome. So you have to be very careful with those drugs. That's why we like Seroquel. Second generation, low dose, only if it's necessary. So in Parkinson's dementia, the treatment is focused on balancing dopaminergic therapy for motor control. This is the person that's going to get things like levodopa, cholinesterase inhibitors, rivastigmine. The dementia with Lewy bodies treatment, this one's going to lean towards cognitive and behavioral support. So what's going to happen in the dementia with Lewy bodies, this is the person you may give someone like valproic acid to help bring them down a bit. That's off-label, by the way. So if you do it, it's off-label. But the reason we're doing things like, say, trazodone or valproic acid for sedation is we're really trying to avoid using an atypical antipsychotic. But if the screen just left, if you can't help it, then you do what you have to do. Okay. Normal pressure hydrocephalus. This is considered a reversible form of dementia. This is the most treatable imposter in neurocognitive disorders. What happens here is cerebrospinal fluid accumulates for some reason, the ventricles enlarge, and the pressures are reading normal. Why would the pressures be reading normal? What also happens to the normal aging brain? It shrinks, so there's more room to not cause that hyperpressure state. So the ventricles are dilated, but you're not getting like the same hydrocephalic problem. You'll call these people the wet, wobbly, and wacky. All right, they have urinary incontinence, the magnetic gait, and the disorientation. I don't call them wacky. This is just for the purpose of remembering for school and test. But so what you do is you look at the feet and see if they look like they're stuck to the ground. The cognition lags behind. There's executive dysfunction, and they have very slow thoughts, and they may be apathetic. Urinary incontinence is a late sign, and you'll do head imaging, and what you're looking for is ventriculomegaly, CT scan or MRI. Sometimes CT scan is enough to tell you. MRI takes longer. You have to hold still long enough to do this test. So that's how you decide. The treatment and the diagnosis is a large volume lumbar puncture, like 60 cc's removed of the cerebrospinal fluid. And what that will do is that will resolve the gait within an hour. If you see that improvement very quickly, this is a neurosurgery referral, if the person can handle surgery, because they can put in a VP shunt and that's reversible and curable. So this is something to pick up on. We've had these patients admitted. I think I may have told this class or the last class, but a woman had this, and the problem is she had a prolapsed bladder and had a pessary put in. So she had pre-existing urinary incontinence. So that got missed. And then she went to her neurologist who said, well, of course you're having trouble walking. You're elderly. Here's a walker. Go to physical therapy. Okay, so now, and then she's upset. She used to be a stockbroker, and she's very upset because she's not able to hang on to her executive function. And she planned her suicide where her and her husband were going to kill themselves together. And she hoarded her Ambien, and she planned for the cleaning lady to find her. Well, she comes into the hospital with her and her husband, and we see her, and we're like, what do you have going on? Oh, my memory's failing, and I don't want to be a burden to anybody. So I said, well, I walk with this walker. And because I do very skeptical medicine, what do you mean you're all of a sudden you're a stockbroker? Now you're not. What's going on here? Give me your walker. So so with the walker, she would walk with a shuffling gait, right? And so they sold her a label of Parkinson's. But if you took the walker away, she would walk like her legs were stuck to the ground. So tell me about your incontinence. Well, I have a prolapsed bladder and I've been incontinent still. I have a pessary. You have a pessary. That's a thing to add wall structure to push up the bladder so you don't leak. And what have you been doing? Well, I just pushed it up higher when the incontinence started and I thought my bladder was getting worse. Oh, I see. So you have incontinence, you have a magnetic gait, and your executive function is failing. Why don't we go scan your head? So the way we worked where I was, we had medicine embedded in psychiatry. And when the patient came, we spent this time saying, this is not my problem, this is your problem, and I'm going to prove it. So I would do my test to prove this is not medical. Of course, you prove that it is medical, and we sent her to lumbar puncture, and she recovered. And then eventually, oh, I didn't need to kill myself. No, you didn't need to kill yourself. Or your husband for that matter. So you can both go home now, but you probably should have a home health aide. If this gets worse, here's what you need to do. The neurologist was not happy that some nurse practitioner called to tell him, I think your patient has normal pressure hydrocephalus. How did you know that? Scanned her head. Why didn't you scan her head? You're the neurologist. You could do lumbar punctures, I heard. Why don't you do them? She's elderly. I know it's harder with arthritis in the spine. You know, they have this thing called the ultrasound. You can guide and. Okay. Suffice it to say, it's reversible. Also, when did I discover it? After I had this lecture about 3 weeks later. This was in 2014 when I went through this program here. 3 weeks after this lecture, this person came walking in. I was like, I heard about this. Let me investigate. And so you might use that in the next couple of weeks to your advantage. All right. So here we go. Go to the next one. Go. Okay. What do we have here? Okay. So let's map these disorders. Cognition doesn't fall into silos. So you start with attention. That's the gatekeeper of all cognition. When the attention falters, everything else follows. Delirium, Lewy body dementia, and vascular dementia all begin here. You have fluctuating alertness, impaired sustained focus, and an inability to filter stimuli. If the attention is unstable and memory never forms, then the next declarative memory, that is the domain of consciousness and recall. And that's where Alzheimer's strikes first. Episodic memories, what happened this morning, kind of lost. And then that's how you're going to tell these apart. When you have this perception and visuospatial processing, this is where the Lewy bodies lives. And this is the brain misreads its own sensory input. So the world turns strange. Objects morph, faces seem unfamiliar. And then they have well-formed visual hallucinations, not psychosis. They have misperception. Okay, and then we have this arousal and regulatory. This is where the neural system that sustains consciousness is a problem, and then they have alterations in their level of consciousness. So that's how you get arousal and regulatory problems. And those are the symptoms you'll have, things like disrupted REM sleep and things like that. So we want to regulate all of that first. Now, delirium comes in 3 flavors. You have hypoactive, hyperactive, and mixed delirium states. Guess which one gets missed the most and is the most deadly? Hypoactive. Because if you don't make noise and come to someone's attention, you get to die, essentially, right? Same when we get to schizophrenia. The negative symptom ones that don't talk and don't scream on the street, they don't get picked up because they're not bothering anyone. We're not going to bother them back. It's the agitated people that come to the level of attention. So hyperactive delirium, this is agitation, restlessness, maybe some hallucinations, and there's some autonomic arousal. These are the falls risk. They're impulsive. Think of hyperactive. This is the way you remember it. Hyperactive delirium. Think of someone that looks like delirium tremens. They haven't had a drink and then, oh, look at that. They're doing this sort of thing, right? And they start picking at nothing. Think of that as your prototype for hyperactive delirium. Hypoactive delirium, this is apathy, inattention, withdrawal. They're not really paying attention. They may neglect themselves. They're probably not eating and drinking. And then that's kind of them. They're just withdrawn. And the trigger, of course, is the acute onset in nature, right? People don't just suddenly do this sort of thing. The mix is where they're fluctuating between these two. You'll see the mixed ones typically in ICU settings. This is what they're calling ICU psychosis because the lights are on, the stimulation's all over the place. They don't really get to sleep well through the night. If you derail your sleep, you can become delirious. Who works night shift 3 nights in a row and then comes to class? You don't know what day it is, where we are, what's happening. Did I eat, sleep? I haven't pooped in 3 days. I don't know what the heck is going on, right? That's delirium. I mean, you have a lot of psychological and physiologic reserve, so it doesn't knock you out, but you can see how in an elderly person, this can make matters worse. Here are the medical triggers for delirium: infections, UTIs, pneumonia, sepsis. Don't miss these metabolic things. Always review the medications and look at the environment. Okay. Also, things like their glasses haven't been cleaned, or they're wearing their reading glasses for distance, or stuff like that. Don't forget the sensory disturbances that can trigger this. And pay attention not only to medications, but the medication half-lives, because that can be the tell. Oh, you're not taking but one medicine, but last week you took these long-acting things, so it's still in your system. It still affects how you're doing now. Also, the other thing to keep in mind, one of the things that happens in dementia is they eat less. right? And they lose muscle mass. Well, when you get to psychopharm, what part of the drug is the metabolically active? The stuff not bound to protein. So as their nutritional intake goes down and they lose lean muscle mass and their protein level goes down, that drug level that was therapeutic at one time may be supra-therapeutic now because it's not enough protein to bind to it. So now you have more free active drug. You didn't raise the dose, they just stopped eating. They lost lean muscle mass. See, that's why I got to weight lift. So that's that. There are some screening tools you can do. Pick your favorite ones, but they're the CAM ICU, and the 4AT. You can look those up. These are built into your EHRs. What you're looking for, the reason we use screening tools, not diagnostic tools, screening tools, is so you have something objective to track at each visit. This is helpful, especially if you're doing things like handoffs. Did you see what I saw? I'm off for the weekend, so the weekend people need something to compare to. That's why you use objective screening tools. I'm not using these tools in primary care or in the outpatient setting. These are very much hospital-based tools. Delirium is considered an emergency. It's a medical emergency that needs to be treated effectively because they can rapidly decline. They don't have a lot of physiologic and psychologic reserves. So here they are. This is just a description of what the tools are. They're readily available. Okay, what time is it now? It is 7:10. Why don't we take a 10-minute break and then we'll do capacity. So let's. Okay, everybody, welcome back. Here we go. All right, so let's talk about this. This is going to be one of the main reasons. Hello, hi, I'm here. We're paying top dollar to be here. Pay attention to me. Okay, so what's happening here is one of the main things that people like to call psychiatry for is this thing called a capacity evaluation. And you will hear all kinds of gospel lore. Oh, you can't do that as a nurse practitioner. Only psychiatrists can do it. Only attending can do it. Only this one can do it. The fact of the matter is, if you are treating the patient for any reason whatsoever, not just a psychiatrist or whatever, you have to be able to determine, does this patient have capacity? Like even a surgeon needs to be able to determine, does this patient have capacity to consent to the surgery I am offering them? This is not a diagnosis. It's saying, do I believe that you, as the patient, understand, appreciate, can reason through, and express your desires for this thing that I'm offering you? There's nothing magical about psychiatry per se, but people want to invite more people to the party, and so we have this thing called a capacity evaluation. Capacity is not the same as competency, and I'll talk about that in a minute. But for the purpose of capacity, you have to demonstrate these 4 criteria: understanding, appreciation, reasoning, and expression. If you are lacking in any one of the 4, you do not have decisional capacity. So if you say have locked-in syndrome, you may understand, appreciate, and reason, but if you're not able to communicate, you don't have capacity. Now, you can make this ability to communicate as primitive as you want. Blink once for yes and twice for no. And we'll go through the whole consent process. Blink once for yes, twice for no. You have capacity. However, if you cannot communicate it, then you don't have capacity. So what does all this mean? Well, understanding means, do you understand what I have just said to you? In other words, I understand that antibiotics treat pneumonia. You understand? Yes. Good. Appreciation means, do you understand that this pneumonia is in you and I'm going to give you these antibiotics? You get that? No, I don't have pneumonia. I know pneumonia and antibiotics go together, but I don't have pneumonia. Therefore, you are not able to appreciate the fact that I am telling you, you have a condition that I want to treat you for. You've just said to me, I understand the condition can be treated, but I don't have it. Now, you could not appreciate it because you're in denial. You have cancer. No, I don't. You're a liar. I want a second opinion. Will you get a second opinion? No, I feel fine. Okay, wait a minute. Go back. We need to figure out that we need to get you to appreciate that you have this condition. Reasoning. Do you understand what I'm saying to you? And can you compare, say, doing versus not doing what I'm recommending to you based on risk-benefit analysis? If you cannot communicate to me a risk-benefit analysis that relates to what I have told you as it relates to your well-being, and communicate it to me, then you don't have capacity. So reasoning is, can you evaluate if I have this procedure, it may help me, but I understand these things can go bad. Reasoning, that's reasoning, okay? And I understand that I can delay, not do, or do something else. You're allowed to make bad decisions. There's no law against it. You can choose to accept and refuse care. Any care you choose to accept and refuse will be held against you because only you will bear the consequences. That's what I need you to understand, right? Get this vaccine. It's set to prevent whatever. I understand what you're saying. I don't want this vaccine. I'm going to take my chances. I'll wash my hands. I'm going to go because I don't know that the risk of that vaccine going to. Okay, good reasoning. God bless. You understand the risk benefit. You can continue on and you've communicated effectively. And you know that there's this thing in the world that's infecting people with God knows what. And you understand that I said to you that this can prevent that and you don't want it and you're allowed to not want it and the low risk. Okay, go ahead, go fine. The problem is the higher the stakes, the more you really need to interrogate their ability to reason. So capacity is a clinical assessment. It changes moment to moment. It's your ability to make a specific decision about a specific situation. Okay, that's determined by healthcare providers, whoever's offering the care. Okay, so they may call you and say, can you see so-and-so to see if they have decisional capacity to consent to treatment? Now, the capacity to consent is not the same as the capacity to refuse. You have to demonstrate those 4 criteria for both accepting and refusing care. So you may not appreciate the situation in refusing the care. So that means you may not have capacity to refuse. You may only have capacity to accept. And I know to you, it sounds like, oh, I feel like we're splitting hairs. It's not the same thing. So capacity is determined by healthcare providers. It's decision specific for specific choices. It's time sensitive and it can fluctuate. And when you document, you need to document those 4 criteria of understanding, appreciating, reasoning, and communication. And you will mark those things. And you want to use the patient's words that helped you say they have the ability to understand, reason, appreciate. But you need to put those words in your assessment. Competency is a legal determination. It's the ability to make decisions and manage affairs. So if you have no capacity and that capacity stays gone for a long time, and maybe a second opinion will also be called, they may then take you to court to have you declared incompetent. And then therefore you need a guardian over your person, meaning to make healthcare decisions, or your property, meaning to manage your money and estate and whatever. Okay, that's the distinction. So competence affects all decisions and it's permanent until it's changed by a court. The way it gets changed is the incompetent person has to get some lawyer to go into court and petition the court for a reversal. So I got called for this. A man had a stroke, massive head bleed, and recovered. But he ran many businesses. So for the period when he had to run his businesses, recovering from this massive head bleed, now quadriplegic in a wheelchair with facilitated communication and the like, he was declared incompetent. He was 48 years old, declared incompetent. I got a call to go and reevaluate his capacity so they can have a new competency hearing so that he can be declared competent. Right now, you are all presumed competent. No court has said you are. You're just presumed that way. And no one's brought a case against you to challenge that. So if someone brings a case against you to challenge it, then they would bring a clinician to do an evaluation, say, do you have capacity? Is your decision consistent over time? Do you understand, reason, and appreciate the circumstances as they relate to your situation? And I said, you do. And they'll bring a second one to challenge me, and they'll say they do. And if depending on how much money's at stake, they'll bring someone to come across and say, he's only a nurse practitioner. He doesn't know what he's saying. He's no good. I have an expert with 3 PhDs. This one says no. And that's the battle that unfolds. That's why your notes are very important. You will really need to be able to document. My other capacity case that I did was this boyfriend and this girlfriend with the wife case. When I met him on the first encounter, I was like, so does he have an advanced directive? Because he's got that look about him, and dementia is a terminal illness expected to decline. And here you are insisting he needs 24/7 care, which means it's affecting multiple domains. So in the first visit, I quickly could elicit that this man had no capacity to make that decision. He would not hold on to information. He did not think it applied to him. I don't need the aid. I can go in the street and do my own thing. He barely could get up and walk, all of those sorts of things. So in my initial assessment, I said he doesn't have capacity for deciding end of life care. Like, that's okay. We already have a living will and there's already a paperwork in place and blah, blah, blah. Okay, great. So girlfriend takes him off and tries to get someone else to say, oh no, he's got capacity. Took him to a psychologist in another state. This person somehow agreed that he had capacity and they changed the will. So what they're going back to find is, well, whose assessment was right? And I said, well, his dementia was so far gone, and I had a formal scale, and he was like 15 out of 30 on the slums and whatever. I'm like, okay, well, he's this far gone. And we know dementia is a condition that's expected to decline, and it's not reversible. So the lawyer keeps trying to hammer me to say, well, maybe it was delirium and you missed it. You misdiagnosed delirium for dementia. That was the argument. I'm like, well, it had been going on for a year or more. That's not delirium. Here is my case, etc. So still being battled out, but whatever. Suffice it to say, that's why the documentation is super important here. So consent also, this is another component to think about. Consent is the agreement after receiving understanding the information. So capacity to consent, this is when they're going to sign a consent form for something. This is also the reason that you cannot have a surrogate consent for mental health services. So we allow next of kin to consent for medical procedures, but when it comes to mental health services, we have to go to mental health court in New York. And we have a judge declare you temporarily incompetent so that the court will consent to, say, your ECT. So this happens a lot when someone comes in with major depression. I don't want to be treated. I'm fine. I'm not talking to anybody. They're withdrawn. They're not eating. They're neurovegetative. And you want to go to ECT. Well, I'm not signing your consent. Okay, we're going to take you to court. So we want the judge to consent for you. We're going to say you don't have capacity to consent. We're going to say you don't have capacity to refuse this ECT because we believe it to be life-saving. And so they go to court and the judge will say, do you understand? I'm not talking to you. Okay, incompetent, sign the papers. And that's how that works essentially. And then what's amazing is they'll do a few rounds of ECT and all of a sudden the person wakes up and they're suddenly engaged and, then they consent. What you want to do is, even though the court declared them say incompetent temporarily and get the consent done, the minute they can consent, you do want to consent them. The rules apply. You might have to go back to court, the length of stay, all kinds of rules play into that. But it's better to do treatment on someone that's willing to have the treatment. It's less traumatizing. So that's what that's about. Okay. That's all I got there. Now, so the criteria for understanding, appreciation, reasoning, and expression apply to both accepting and refusing treatments. Higher scrutiny for refusal. So refusing treatment offers require a more thorough assessment, especially when significant harm could result, such as in the case of I need you to go to ECT because if you don't get this, you could die. And because you're not eating, you're not drinking, you've developed a bed sore. It's horrible. You need to go. Right. So that's the problem. Thresholds are different. So if you're accepting for lower threshold, lower risk standard, so that's how that's determined. They only typically will call psychiatry if it's a major decision, dialysis consent or refusing dialysis. We've even had to go to court to get someone to consent to a nephrectomy because it was cancerous and curable with the surgery. And he was psychotic and not in a position to consent to it. The problem is the minute he left the locked psych ward, the court order went out the window because it only covers the psych hold. So then we would transfer to medicine, get the next of kin to consent. He would consent and then bring him back to psychiatry to recover. And every time he changes positions, the law that governs him changes. So you can see how tedious and laborious this gets. The fact of the matter is this was a curative one and done surgery. Everyone was recommending it. 2 opinions were given. He had the surgery eventually. They recovered him with a nephrostomy tube in psychiatry. Imagine how the psych nurses felt about that. They did not like it, but suffice it to say, he did well, went home, and was able to get on with his life. But anyway, in emergency exceptions, implied consent is permitted for imminent serious harm. So this is like if someone is actively trying to, say, kill themselves, you can restrain them without consent. You can be 50 to them. You're doing things to prevent imminent serious harm. That's how come in the ER, they come in stark raving mad and they're beating and fighting and whatever. Sir, I'd like to give you a punch in the nose. Okay, here, hold them, security, B-52. Okay, right. That's implied consent in an emergency situation. You can rest assured that documentation is important. Now, document the patient's own words to capture these statements. You want to put direct quotes in the chart as much as possible, and you want to link to understanding, appreciation, and reasoning as to how you understood it. You also want to clearly document alternatives that were discussed. And if they can't have the conversation because they're so fixated, so ruminative, so perseverative, they're not grounded in reality, you obviously cannot get consent from somebody that's not grounded in reality, right? Unable to consent, lacks decisional capacity. That's the note. But if they are able to engage in the conversation, that's also what you're documenting. You also want to make sure you have dealt with reversible factors of delirium. So if they're uncontrolled pain and they feel they're being coerced, you're not going to give me pain medicine unless I agree to this. You don't want that. Your job is to advocate for the patient and make sure that they're getting their needs met, the care is rendered so that they can think clearly and express their wishes. Any questions about capacity? You got it? Yes? If the guardian loses capacity while they are responsible for somebody else, sure, it does happen, especially in the elderly situation. You have to ask yourself, who is the patient? Right? Are you responsible for the guardian or the patient? And if you are talking to the guardian and the guardian looks like they have no capacity, then you have to have a new guardian appointed. Oftentimes, you will find on these advanced directives, there will be a backup guardian. If in the event so-and-so can't be reached, reach out to this person. And you'll also see a line, this person knows my wishes regarding nutrition, hydration, et cetera. And also, we have medical orders of life-sustaining treatment in New York. You want those filled out on people as much as possible. New York always defers to a healthcare proxy over a living will, though, too. So if they cannot have capacity, someone else will have to decide on their behalf. And you may have to go to court right away. It might be emergent. If it is emergent, you do that in the hospital. If it's life-saving, we presume capacity. There are administrative procedures to get around it, but you're responsible for who is the patient. Ultimately, you need to make sure the patient is getting the care they need. And you have to make sure that the guardian is acting in their best interest. So sometimes, and this is an issue of like elder abuse and exploitation, where I want you to keep them alive. Why? This is not helpful. It's terminal. It's expected to decline. Well, if they die, we lose the rent stabilized apartment. Oh, I see. They're the name on the lease. So now you're no longer acting in their best interest. You're acting in your own interest. And so now we need to involve a second person, court, legal, et cetera. Yes. Say again. No, because the patient is lacking capacity. That's the one you're responsible for, right? And it's the guardian that is not consenting to the appropriate treatment for the patient, and they're making it out to be like they are worried about the well-being of the patient, but really they have a secondary gain. They are malingering, but they're not your patient, so you can't diagnose. Yeah.
Somebody's diagnosed with early Alzheimer's and they have good days and bad days.
Yep.
This person decides to create mental living well. Does that automatically?
They need to do it on a day where they have capacity. So they do have good days and bad days. One of the tells is consistency. If they are generally consistent when they have the capacity, that's far more informative and helpful than if they are radically changing day to day. If they are radically changing their decision day to day, that probably means they don't have capacity because it's not consistent communication. Wearing them down, essentially. Right. So you would have to document how highly suggestible they are and how they're motivated, right? So in the note, I would say the patient would change his mind if I gave him a chocolate chip cookie. If I smiled at him and told him how great he looked today, he was willing to go along with whatever I did. He's highly suggestible. So you have to indicate that in your note so that can be understood. You know, yeah, your notes are going to be really important when it comes to that sort of stuff.
That surgeon could not sign a patient out of the hospital.
In psychiatry?
No,
Right.
Yeah, they're like,
The parent can. Yeah. I don't know if that's accurate. A healthcare proxy should be able to sign the patient out AMA. That person may have a case because what if I totally disagree with the care you're getting? I mean, I have a friend, unfortunately, who recently just died this week and was getting horrible care. I didn't push her to get out because she didn't want to get out. I'm like, this is terminal, you're going to die anyway. So why am I going to jump up and down and cause a scene? But suffice it to say, this is horrible care. You're going to die from the bad care before this stage 4 cancer that you have. But yeah, I mean, you have to decide where that's going to go. That's illegal. That healthcare proxy could go to court, get a lawyer, compel the hospital. You know, you have to be careful what people tell you the law is versus what your hospital policy is. Right. Hospital policy can be more conservative than the law, but technically you're false imprisoning the person. Can't false imprison people. They have a right to not be with you. Yes.
Well, I recommend something very thing where that after application, they should be kind of a hospital.
Mhm.
They want a wheelchair from out of here, and everybody's fighting them. Can't do this. They pulled security on the healthcare proxy. They started fights. It was the whole thing. Ultimately, the healthcare proxy got a wheelchair, took that, left it out, and they had to do like a tablet thing. You can't between two hospitals.
Yeah, we can't go from one ER to the next, but the patient can leave AMA and I want to go to a different hospital. Right.
They wouldn't let them sign.
Yeah.
And we'll put him on.
Right.
That is more conservative of their policy rather than the law,
Right.
like you said.
Yeah, you will find that hospitals will swear up and down it's the law. It's not. They have legal counsel on retainer to advise them on the best way to interpret the law to reduce their liability. But at the end of the day, you want your loved one cared for in the best possible place. And if that means physically moving them, I mean, I've had some cases where they say, listen, I don't want to go to that hospital. So instead of calling 911, we're going to call a private ambulance, right? Because a private ambulance will go where you tell them 911 has to go to the closest hospital. So sometimes they do that thing. Transfer? Right. Right. Okay. Right. Well, then you have to say, does this person have capacity? Do you understand the risks and benefits of what is being presented to you here? Right. And can you communicate and understand, et cetera? So there are some ethical things to keep in mind. So autonomy and beneficence has to trump all of this. That's really what we're going after. You don't want to make the person worse off having met you. So autonomy means that they're more than allowing choice. It also means that you're ensuring the conditions for the choice, clarity and comprehension, and you can't coerce them. Beneficence, this compels you to act in the patient's best interest. But whose definition of good is what matters here. And non-maleficence means you should not be actively trying to harm them and they shouldn't be worse off. So you can't, for example, threaten them with an unrealistic risk to get your way. If you leave, you will die. When will I die? Tomorrow, in 5 minutes, in a year? Then I have time to get there if it's next year, right? So that kind of thing. And you'll notice a lot of people will try to say risk of death and infection and harm and et cetera, et cetera. And I feel like that, you really should honor the patient's autonomy as much as possible. That's really what this comes down to. Because at the end of the day, if harm does come to the patient because of the care you rendered, you've also opened up to a whole bunch of liability because the patient's advocate was actively saying they are in the wrong place, the care you're doing is wrong, and they died. And now what? Right? So that's what the lawyers are weighing out when they advise the hospital, should they go or shouldn't they go? Okay. So the right to refuse is absolute for people with capacity. Ethically, it's not considered abandonment because it's respecting their right to self-determination. So involuntary treatment is the exception of this. It's justified only when two conditions exist. The patient has to lack capacity and the patient has to possess imminent danger to self or others or is gravely disabled. And so that's the only reason you can trump self-determination. All right, so let's take a look at this clinical cases now. So take a look at this case here. We have a 78-year-old woman with mild Alzheimer's. She has a MoCA of 22 out of 30. She presents with a UTI. She understands her diagnosis and says, I know this infection could get worse, so I'll take the medicine. That's the picture of capacity, not because she scored above the cutoff, but because her reasoning and appreciation are consistent with reality. So this woman, even though she's severely demented, has decisional capacity to accept the antibiotic treatment. She knows she has a UTI. She knows what antibiotics do. She also recognizes the risk of not taking the antibiotic. That's the appreciation. She compares outcomes and chooses prevention. And she repeats her choice clearly and consistently. We don't see any coercion, there's no confusion, and there's no contradiction. So her decision may be simple, but it's informed and it aligns with her values. So someone with a diagnosis of mild cognitive impairment does not automatically equal a lack of decisional capacity. The diagnosis does not make a decision invalid. Only the loss of reasoning and appreciation and the ability to communicate too. Here's another case. Okay. So refusal. So this is a 72-year-old man with hypoxia and a UTI, repeatedly removes his oxygen saying, I don't need this. My breathing is fine. His oxygen saturation is 88%, but his insight is 0%. You can see he's delirious, disoriented, and fails to recognize his risk. He can parrot words, but can't retain meaning. So his understanding is limited. His appreciation is absent because he denies his illness entirely. No insight. Reasoning is disorganized because his logic fragments under scrutiny, and the expression is inconsistent and fluctuating. So this is the classic pattern of the incompetent refusal, not because he disagrees, but because he cannot comprehend the stakes. So what's the ethical path here? You treat under implied consent, correct any reversible causes, and then reassess him daily. Capacity in this case is lost temporarily due to the delirium. So treat the brain, and then the person hopefully will come along. In psychiatry, you never want to confuse refusal with autonomy unless cognition and comprehension are intact. Okay. Here's another case here. It's a bit of a gray zone. So you have an 83-year-old man with vascular dementia and a MoCA of 19, new onset atrial fibrillation, and he's a high fall risk. He says, I'd rather risk a stroke than a bleed from my fall. So this sounds irrational, but is it? What do you say to this guy? He understands what stroke means. He is personalizing the risk, 3 falls a year. And he's logical because he's prioritizing quality over longevity. And he's consistent. It's steady with his values. It's based. So yes, he meets decisional criteria for capacity. This person can refuse the anticoagulant. His choice doesn't make you feel comfortable, but he has the right to make this decision. He's expressed it clearly, and he says, I understand the risk. I don't want to die of a brain bleed. So that's kind of gray area there. Question? That's very common.
Yeah.
Yeah. Well, it is and it's not. I mean, you want to die of a brain bleed or have a stroke? He knows he's a falls risk. That's a pretty good criterion. I don't want to fall and bleed into my head. Right? So you do rate control, you do physical therapy, and you hope for the best. You know, some people will do homeopathic anticoagulation, say, well, will you take an aspirin? Why? Because it'll make your doctor feel better. How about a baby aspirin? How about 2 baby aspirin? I've seen people do this kind of weird negotiation. How do you feel about Plavix? You know, they do this sort of thing. The official guideline is direct oral anticoagulation, but he doesn't want that. He certainly doesn't want Coumadin. Certainly doesn't want Lovenox or heparin. So that's the discussion you have to have. Okay, medications for this condition. We have cholinesterase inhibitors. Here's how they work. They inhibit acetylcholinesterase and they increase synaptic acetylcholine. The common drugs here are donepezil, rivastigmine, galantamine, and this is all intended to support attention and working memory. The problem, of course, is the nausea, the GI upset, the bradykinesia, and the risk of falling. So this is going to be the decision that you have to decide. And the other part you have to decide is you are adding this likely into an already mix of polypharmacy. So now you're adding one more to the equation. So there really has to be a big risk-benefit analysis in using these drugs. They don't really do much to slow the disease process per se. You can do a trial and see if they get some benefit from it. If they don't get benefit, it's not unreasonable to stop it. If they've been on it a long time, it's not, you will certainly notice a significant decline. Well, you may notice a significant decline in function when they go off of it. A lot of family members want this because it feels like they're doing something for the dementia. But this does not extend mortality. This doesn't extend life. Doesn't necessarily reduce morbidity. And so there's a big risk benefit analysis that has to happen here. I think the problem is oftentimes it started too late. So I would say if you're going to do this, this is someone probably for like mild cognitive impairment or, early in their dementia course, if you're going to get a big bang for the buck on this. Okay, these are the NMDA antagonists. So these are commonly used in concert. I don't typically see these as standalone. These are kind of like a surge protector. These dampen an electrical storm in the brain. So what this does essentially is this stabilizes cognitive control. It's a mute, essentially, for excitability and irritability. This is indicated for moderate to severe Alzheimer's, and it's often added to the cholinesterase inhibitor. The problem is this can cause dizziness, orthostasis, confusion, and mild disorientation. So now what do you do? And the question is, maybe it's just an acclimation thing, or did you just cause a delirium? And how will we know? So that's the problem with this medicine. You put it on, you have this expected adverse effect. Do you ride the wave or say it's delirium and take it off? That's the decisional balance you have to figure out. In general, I'll tell you my own bias, I generally don't start these meds. I continue them if they're on them, but I generally don't start them. I have not appreciated a big bang for the buck in these patients, and I feel like the polypharmacy and risk of falling as a result is much worse. And then the GI upset and the diarrhea/constipation is another major factor. So I tend not to use this. But they will say this is good for reducing background noise, essentially. If the patient is just very distracted, maybe this is helpful. I try to go after it with treating the depression, anxiety with like a mirtazapine or an SNRI or something like that before I do this sort of thing. Also, I try to go after the sleep first. Okay, so let's talk about Lewy body dementia meds here. So these people here, the Parkinson and the Lewy body, these are dopamine deficient states. So blocking dopamine can be catastrophic in this population. So up to half of all Lewy body and Parkinson dementia patients will experience severe adverse reactions to the antipsychotics. I've had good luck with quetiapine. That's about it. I generally don't go to the others. Only if they're at the point where they're eloping and punching and running and really like dangerous, do I go to something like olanzapine for the sake of I need to sedate them at night at least to get them to sleep. And then I can generally get away with once a day dosing because the half-life is sufficiently long. Give it at bedtime. If I can get them to sleep, sometimes this is enough to help reconstitute them. But I really try hard to avoid these meds in this population. But what you're trying to do is go after sleep cycles here. Okay. So these are the meds that can make your story worse. And like I said, the person with dementia is at increased risk for developing delirium. So anticholinergics are bad. The antihistamines, diphenhydramine, TCAs, oxybutynin is used for overactive bladder, which they really like because they don't want to keep rushing to the bathroom. But keep in mind, it can be can cause constipation, urinary retention, dehydration, and the like. Now, it's interesting because why do you think they're getting dehydrated? Well, they have overactive bladder, so they stop drinking on their own. Well, that puts them behind the eight ball, right? So they're dehydrated because they think they're doing something, but it's making the delirium manifest itself. You want to be careful with CNS depressants, these cloud cognition. I'm amazed how many elderly people are on benzos, so I do a deprescribing. I spend more time deprescribing with the elderly to mitigate delirium than I do adding meds on. You will get a bigger bang for your buck in doing that, and they want someone that will do it cautiously. So psychiatry, you can see them more regularly. You can figure out really what's going on, and you have the time and room to do this. So this can be very helpful for you. Also, you have to be very mindful of polypharmacy. You can wind up over-treating. So if you ever have a medicine that will do a lot of things for you, like say, nightmares, prostate, blood pressure, all at once. Oh, I love my doxycycline for that. Alpha blocker works great. Why? Blood pressure, prostate, and nightmares all together, one pill at night. Would cover 3 bases. So you can look for meds that will do that if you can find it. Okay. So let's look at first-line pharmacotherapy. So for Alzheimer's, you begin with the cholinesterase inhibitor if you're going to go down that path, and then you'll add something like memantine. You want to be stage-based in your treatment, and you got to watch out for the GI side effects and cardiac side effects like bradycardia. What that means is if you're going to put these meds, you got to check vitals. And you'd be amazed how many psychiatric practices don't check vitals. If you're going to prescribe things like antipsychotics, you need to do a metabolic syndrome workup in advance, and someone needs to check that QTC. So if you're going to do it, you own it. You don't want to make the person worse off. So that's important to do. If you're contending with Lewy bodies or Parkinson's, well, then you want to be gentle in your approach and avoid the antipsychotics and be mindful of all their sensitivities to meds. For vascular dementia, your main thing here is work with primary care, or at least facilitate control of the hypertension, diabetes, and lipids. Think about antiplatelet therapy in these people as well. You may not prescribe all of this, obviously, but you can certainly speak to their loved one or that and make sure that you're dealing with primary care to get this dealt with as well. SSRIs and trazodone are quite good in this because it can help with things like the disinhibition in frontotemporal dementia. It can also help with anxiety if that's making it worse, and the trazodone can be useful for helping sleep. With respect to normal pressure hydrocephalus, the big thing here is going to be the evaluation, imaging, and the therapeutic lumbar puncture. Okay, so that's the pharmacology. There are non-pharmacologic things you can do. The goal here is to restore the brain's environment so that it can recognize rhythm, routine, and relationship. So you want to start with reorientation and sensory optimization. Turn down the background noise. Delirium is disorientation essentially in front of you. So these are people you're going to show clocks, calendars, familiar faces, personal items. These are all going to be external anchors for them to read their environment. So a patient who can't see or hear properly is going to be likely to misinterpret. So before you reach for the Haldol, make sure that the lighting is good, you're on eye level, you're not shouting because they can't hear those high-pitched voices. Bring it down an octave. They can hear lower pitch tones. How are you? Did you sleep okay? Keep the questions simple. We don't need to have poetry here. We just need to know, are you in pain? Have you been to the bathroom? Are you eating, drinking, sleeping? Is there something you need? That sort of thing. And then if they can get oriented with that, then you can hopefully make some ground. The goal is to regulate the sleep-wake cycle because that's essentially the biggest culprit here. So you want to keep nights dark and quiet, and then you want a lot of natural light during the day. Put the shades up and get them into the sunlight so that they can reestablish a circadian rhythm. The other thing is mobility is important, especially in delirium. So physical therapy might be appropriate to get them up and moving if they're not willing to do it. Or maybe the aide can have a home exercise plan to do with them. Make sure that you've dealt with pain and the like. And any device you put into them is definitely going to be a can of worms. So these people may get a catheter if they're in the hospital, and that's really going to set the stage for something bad. Clear the clutter and make sure the IV is absolutely necessary. And if they can drink, it's better to hydrate orally than by IV. And also make sure you've not neglected the bowel routine because a lot of the psych meds are constipating. So if you're not sure, you can always shoot an abdominal x-ray to see if they're constipated or not. I mean, sometimes you have no choice but to do that because I don't think psychiatry is going around doing rectal exams and checking the vault. So you don't do that. But you can do an abdominal x-ray and say, oh, retained stool, why don't we give you something for that? So when the diagnosis shifts from delirium to dementia, the therapies now change. So the first principle here is clear communication. So you don't want to argue with the patient, and you also want to teach this to the family member. You want to agree as much as you can and then try to redirect them. You want to kind of reminisce them. So don't say, you remember when you used to like, no, obviously they can't remember. That's the problem. So don't do that. Just say, we used to do this. Don't say, do you know who I am? Stop quizzing the patient. That's the most infuriating thing. They don't know who you are and they're stressed out about it. You want to validate as much as you can to try and diffuse the agitation. What you want to do is get a connection with them. You're not looking for deep conversation. You're just looking for them to feel connected. You want to support the independence as much as possible. So give structured, limited choices. Do you want tea or water? What do you want to drink is not helpful. It's too many choices. So limit the choices, make it binary. You want to preserve as much autonomy. You want them to make as many decisions as possible, but obviously that's going to be limited. So decide between two things is better than an endless menu of options. And so this is a lot of what you will do with family members. How do you communicate effectively with someone with dementia? This happened so commonly that I had to make a podcast about it because I kept repeating this speech 100 times to patients. So now I just send them a 3-minute podcast about how to communicate with dementia patients, and then they can hear the different kinds. And how do you know is the big question. How do you know they have dementia? So you really get very familiar with this so you can articulate it to them. You didn't even scan their brain. You don't always have to scan their brain. Sometimes the picture is very clear and they can't sit through the scanner. So especially if they're far advanced. The other thing is people with dementia will very much read emotional tone. So you can't seem like you're yelling, and you might have to raise your voice a little bit in a pitch and make it seem a little less stressful. You're trying to meet the person where they're at. You also will be in a prime position to facilitate discussions around advanced directives and healthcare proxies. So if they're early and have a lot of capacity and they're in the mild cognitive impairment state, this is where you want to do it. Put your affairs in order now. Make out the will, the medical orders of life-sustaining treatment. What do you want to do for end-of-life care? Well, all that stuff. You do that early on. Now, you can have this conversation because there's nothing magical about it. You just want someone that has time rather than a 10-minute primary care visit. Here, fill out this form. I'm going to sign here. Done. The other thing is if they accept the diagnosis and they know it's a condition that's expected to decline, you can do a DNR if that's something that they want. I do DNRs all the time in the community. And what you're going to do with that is say, when you get to the point you've severely declined, you can make the referral to hospice. And the whole goal is to make this a natural death at home if that's possible. So that's why you're monitoring them frequently. You'll do things like, the tell, by the way, when they get near the end is when they get more withdrawn, isolated, and they're not eating as much. When the not eating drops off and they have weight loss, you know you're kind of in that final phase of the dementia decline process. So having all this done in advance when they have as much autonomy as possible is helpful. So where do you refer them? Elder care lawyers. There are forms online. You can do all of those sorts of things. So you may be called for decisional capacity for advanced care planning if no one did this in advance. And so you're looking for consistency over time. Do you understand you have a condition, whatever that condition is? Do you understand that the condition's expected to decline? They may not be willing to accept that. And how do you want to proceed with respect to, my wife knows, I know. When the time comes, I'll deal with it. If they keep kicking the can down the road, they may not be accepting of the condition, which means they're not understanding and appreciating it, which means they may not have decisional capacity, and someone's going to have to decide on their behalf. So that's the discussion that needs to unfold. And you may revisit it to see if it keeps changing. Like if one day the firstborn is the leader of the pack, and the next day, no, I hate my children, I'm going to give it to my, okay, wait a minute, this keeps changing too much here. So that's a way to tell if this is reliable or not. Now, how do you care for these people? Well, depending on how severe it is will determine where they're going to be placed. So it could be something from mild to moderate, disruption to IADL. So you can get minimal support for that. Manageable behaviors, there's no wandering. That's the person where you can automate the home, put in the grab bars, maybe notes by the door, start labeling things. That's mild cognitive impairment, early stuff. If they decline beyond that, the next level of care is going to be something like daytime supervision, because they're okay once they're in bed for the night. Structured activities. So this is going to be really helpful. One of the biggest problems is boredom. So rather than you asking them what they want to do, you will give them a list of options. Monday, let's go to the Met. And then Wednesday, we'll go to a matinee. And Tuesday, someone's coming to take you to lunch. And Thursday, you have the physical trainer coming. And Friday, we're going to go to the, like that. So they can plan it. And you put it on the calendar so they can see what to look forward to. New York is a unique place to get old if you have money. I mean, we have companies here, one that will just send, what they do is they take liberal arts majors, artists, performers, singers, pianists, those sorts of people who are between gigs looking for work. They pair them with people with mild cognitive impairment and dementia. It's basically like Rent-A-Friend. right? And you go hang out with this person, you'll take them to the theater and you'll take them to lunch and you'll basically engage them because nobody's here to do it. Otherwise, they're left to their own devices in the apartment. It's a non-medical companion. Well, when they decline more, that can become like a home health aide, and they can help with bathing and feeding and toileting and market runs and things like that. They decline more, you can make that a 24/7 operation. If that's not sustainable or they have the room, you can maybe make it a live-in situation. And you'll learn all the rules, but that live-in needs 8 hours of uninterrupted sleep. You need someone to cover those sorts of things. There are also geriatric care managers. They're called aging life care consultants now. These are people that are typically social workers because nursing gave this up for some reason, but they help coordinate the home health aide, the activities, the doctor's appointments, the testing, the specialists. They call people like me to make a house call, stuff like that. So there is a whole bunch of support services, home alarms, medic alert, I've fallen, I can't get up. They have Alexa and AI that's automated the home. One of the assisted livings has AI built into their monitoring system. So the AI learns the patient's pattern of behavior. So so-and-so gets up 3 times a night to go, or once a night to go to the bathroom. Well, this night, the AI noticed they got up twice to go to the bathroom. And they've noticed this pattern over 2 or 3 nights. It alerts the nursing office to say, hey, someone's peeing more in the night. Maybe you should call the primary care provider and maybe they should do a UA. Do they have a UTI? Or it learns that, hey, normally they go in the bathroom and they spend only 5 minutes in there. Today, they seem to be spending 10 minutes in there. And this goes on for a couple days. Why don't you put a call out to the primary care provider? They may have constipation, right? So you're picking it up before they fall, before the constipation becomes obstruction, that sort of thing. So you're just basically having passive eyes. They might say it normally takes them 2 minutes to get out of bed. This time they're taking 3 to 4 minutes to get out of the bed, and they're walking across the room much slower. They're just shuffling their gait. They're not really picking up. Can you call primary care to work them up, maybe order PT? So a lot of these assisted livings are using these passive devices to monitor because labor is very expensive. I mean, the going rate now for a home health aide, the agencies are charging 35 to 40 bucks an hour for a home health aide, right? The aide's probably getting 20 to 25 an hour. RN care right now in the community in the home is going anywhere for about 100 to 140 bucks an hour. That's what the company's charging. So they're probably the nurse is probably getting 80 to 90 to 100 bucks an hour for that. But can you imagine how much that adds up over time for 24/7 care? So you try to find as many automated ways as possible. The room can learn your pattern, you know, motion detectors, the light comes on, hallway lighting, ambient lighting, things like that. So there are options. And then finally, the end of it is essentially a skilled nursing facility where they need full ADLs, higher staffing ratios. But of course, if you've worked in a long-term care facility, you know what the staffing ratio is like there. So my recommendation is if you can afford to do it at home as long as possible, I highly recommend that. Because when you relocate them, they're going to have this relocation delirium as well. So that's a problem. The other people you need to care for in this, oftentimes it's not the patient because they lose an awareness. And so you wind up having to treat their family members. So you want to give them all the various support services that they could possibly have. I said you want to give them all the support services they need in the community so that their needs can be met. So in New York City, we have the Alzheimer's Foundation. They have an interesting thing where they do community outreach and teaching. They have a model Alzheimer's apartment. And you can go take a tour of this thing, but it's a high contrast apartment that caters to all the sensory deficits that someone with Alzheimer's may develop as they age. So for example, the toilet room has like glow tape around it. It's brightly marked, so they know exactly where the bathroom is. The plate and the placemat is brightly colored. Things have big handles. The doors are textured so that if you know what your room is by looking, it's elevated, it's declined. So they give you a lot of varietal texture, but check it out. It's a free tour of the Alzheimer's Foundation. You can look it up and see what they have to offer there. But it's meant to be a teaching guide for people to equip their homes in dealing with people with dementia. And then, of course, the big thing is going to be consistency in monitoring. So the problem in primary care is we don't like to see you if you're not having a problem, right? Here's your antihypertensive. See you in 3 months. You can't do that in psychiatry, especially when you have a condition that's expected to decline. You need to see them with some degree of consistency. It may be weekly at first, but it can go down to biweekly or monthly thereafter. But you're looking for, where are we in the declining phase? What other examples do I need to put into place to anticipate your needs so that we don't get to that point. And it gives you an opportunity to revisit deprescribing. So when you get to 80 years old, you're like, do I really need to continue this cholesterol medicine in your advanced dementia state? Why don't we talk to primary care? Or in my case, I take care of it. You don't need that anymore because I bundle them together when I take care of them. But, do we need to have, maybe the blood pressure is too well controlled. Sometimes you need to dial down the antihypertensive. So that's somewhere that needs to be picked up because primary care is going to say, oh, you're stable, you're quiet, you're fine, leave well enough alone, off we go. But those meds need to be revisited. Someone needs to weigh the patient, check on eating and sleeping and the like. And that's where you guys have time to do that sort of stuff. Yeah.
Have like the later stages of dementia start like forgetting that they're mean. I like my grandma, like when she was in the last stages of dementia, like she was on the floor like begging and like before that she was like, so much knee pain and this, but like I just feel like they forget it. Like
They forget their pain.
yeah.
It's a brain processing thing. So the problem with Alzheimer's and the like is the brain is misprocessing inputs. It may not be able to process the pain input. The other interesting thing that people don't realize is as dementia declines, depression tends to get better because they lose that self-awareness. And that's a hard thing to see. So I've just recently taken someone off their antidepressant because their dementia had severely declined. She's not depressed. She just doesn't care anymore. She's withdrawn. She's not eating as much. I don't need to keep this medicine on her. So why do we need to keep it? Yeah.
With the hallucination,
Mm-hmm.
so they believe that these things are actually happening.
If they're demented, yes. If they're delirious, no. Right.
So do you feed into that?
No. You don't have to validate everything.
You, as a nurse.
Yep.
You side. Sometimes like you have to.
You can go along. I wouldn't validate it. You have to choose your battles. So what you're going to do is, I don't know, give me an example of a hallucination that they're having. Hallucination, you said, right?
Hallucinate.
Not delusion. It's a difference. Say again? Why are there dogs in your room? I'll check. Let me see. Oh, really? That's all. You don't have to go into it. Oh, I see the Chihuahua and the, no, you don't have to do all that. There are dogs in my room. Okay. It's not going to change anything. So you don't want to argue. You never want to argue with these people. Okay. And it's important. We'll talk about the difference between delusions and hallucinations later on, but suffice it to say, a delusion is a deeply held belief despite evidence to the contrary. But in someone like them where they can't appreciate, understand, or reason, it's not about evidence because they're not weighing evidence at that point. They're not even understanding the evidence. Now, this is a condition. It's a neurocognitive deficit. We're going to call traumatic brain injuries. This is a problem where it's kind of like chronic debilitated. They don't normally die of the traumatic brain injury if it's caused lasting effects. But what happens here is they're at risk for depression, anxiety, PTSD, and the like. But after the trauma is over, it's not expected to decline at the level of the trauma. Can this person get delirious? Yeah. Can a TBI develop dementia? Yeah. But that's the new condition. This TBI, they may lose the ability to understand, reason, act, right? And they may not be able to do their ADLs, but they're going to be at this plateau for a very long time. So this person is who you're going to see in a long-term care facility. And you have to not underestimate, can this person become depressed, anxious, etc.? Because depending on their level of awareness, they may get utterly frustrated with their life, and it could be a reasonable expectation. So depending on the level of traumatic brain injury, they may actually benefit from talk therapy if they can understand and reason. But if they can't, it's supportive care and anticipate their needs and deal with the same problems of constipation, dehydration, and the like, because especially if they're immobile, immobility problems are a big factor as well. Also, clots can develop if they're immobile. You'll be amazed how many times they forget, oh, maybe they had a stroke, but we can't tell because you're generally immobile, but that could be the reason for the change in cognition. So you'll work with rehab services there, but a lot of it's going to also be contending with anticipatory guidance and explaining to the staff and to family members what's going on. All right, so here's the triage situation. So the first step you want to do when a patient presents with confusion, start by ruling out delirium. You may want to use an objective measure and always check vital signs and metabolic parameters Do not jump to dementia just yet. What you're looking for are reversible causes. Correct things, obviously, like hypoxia, infection, electrolyte, constipation, dehydration, fix the hearing aid, adjust the glasses, put the clock in the room, give the reorientation markers. And once that's resolved and the delirium's ruled out, then you need to ask, is there an underlying dementia situation here? And then you can do that diagnostic work up there. Don't miss delirium just because you know of their dementia. And what you're looking for is attention, memory, and executive function. That are the markers of cognition. And then once you do that and you determine where they are at that level of dementia, if it's early, middle, or end, you're going to help have this conversation about advanced care planning, figure out what their values are, see if there's anything in place so you can treat them according to their wishes and promote their level of autonomy. So delirium, medical emergency, pay attention. It's like the vital sign of the brain here. You want to look at what's reversible. Lewy body and Parkinson's, the distinguishing factor is the 1-year timeline. That's the distinguishing factor there. When you give medication, you want to link it to the domain circuit that's affected. Don't just say DSM criteria, check a box, insert a pill. And capacity decisions are very much limited to situations. It can come back when they don't have it. And so you're looking to figure out, do they understand, appreciate, reason, and communicate consistently? So this is a list of resources and references here that you can pull up. If you just Google these, you'll get the free resources for yourself or for the patients. That's pretty helpful to contend with. MoCA is freely available online. You're not supposed to be using the mini mental status exam. It's now patented. So there's a free one called the SLUMS, stands for the St. Louis University Mental Status Exam, put out by the VA. I highly recommend that one. It's user-friendly. You can print it off as often as you like. So that's helpful. And then the MoCA has several versions, by the way. Oh, interestingly enough, there's a thing called a MoCA certification. You don't actually have to have it, but, you know, just, and not going to worth it for me, but if you get it, the reason people will do a MoCA certification is they feel if they get called into court that it's more, it bears more credibility because you've been trained and certified. It's an online course. I think you get a CE for doing it. So if you need CE in your life, you can go ahead and take this MoCA certification course and do it that way as well. That is all I have for this. Let me stop this recording here.